My name is Mohammad Al-Haddad, and I am an assistant professor of medicine at Indiana University Medical Center in Indianapolis, Indiana. I will be presenting our recent study describing the role of endoscopic ultrasound in the preoperative evaluation of cholangiocarcinoma. Our study represents a large retrospective one conducted at a tertiary referral center for pancreatic and biliary disease. Despite the recent improvements in abdominal imaging, accurate preoperative diagnosis and staging of extrahepatic cholangiocarcinoma remain difficult. The classic mainstay for the diagnosis of malignant biliary strictures has been endoscopic retrograde pancreaticocholangiography, or ERCP, with brushings, but the results have been very inconsistent. EUS is well suited as a diagnostic modality to evaluate the entire bile duct because of the proximity of the ultrasound probe to the course of the duct. In this study, we sought to evaluate the utility of EUS for preoperative evaluation of cholangiocarcinoma and its ability to detect the lesion, make a tissue diagnosis, and accurately assess surgical resectability. We have initially screened 228 patients referred for EUS at our institution for biliary strictures between 2003 and 2009. Of these, 81 patients had cholangiocarcinoma. 51 patients had distal and 30 patients had proximal lesions. We found that tumor detection by endoscopic ultrasound was superior to triphasic CT scan, in specific 94% detection rate on EUS compared to 30% only on CT scan. MRI, on the other hand, was slightly better than CAT scan, although inferior to endoscopic ultrasound, and identified the tumor in 42% of the cases. EUS identified cholangiocarcinoma in all 51 distal and in 25 out of 30 proximal tumors, the difference between identifying proximal and distal cholangiocarcinoma being statistically significant. EUS fine needle aspiration was performed in 74 patients, or 91% of the cohort. The overall sensitivity of EUS FNA for the diagnosis of cholangiocarcinoma was 73% and was significantly higher in distal compared with proximal cholangiocarcinoma, being 81% in the distal compared to 59% in proximal lesions. The diagnostic rate of fine needle aspirate was significantly higher than ERCP brushings, found to be only 25% in this series. We found that the sensitivity of EUS FNA in patients with a biliary stent was lower than that in patients without a stent, 70% compared to 90% in this cohort. The majority of patients had plastic biliary stents in this case. 15 tumors were definitely unresectable. EUS correctly identified unresectability in 8 of the 15 and correctly identified the 38 out of 39 patients with resectable tumors. CT scan and/or MRI, on the other hand, failed to detect unresectability in 6 of these 8 patients. For nodal staging, EUS detected abnormal lymph nodes in 2 of 23 patients with a sensitivity of 9% only, but correctly identified 21 of 22 patients without malignant lymphadenopathy. CT scan, on the other hand, detected abnormal lymph nodes in 4 out of 22 patients with nodal metastasis, but correctly staged 18 of 20 patients as N0. Our study is a retrospective one, but is among the largest EUS series with surgical pathology used as the gold standard. This study sheds some light on some important issues related to the diagnosis and staging of cholangiocarcinoma. First, we found that EUS is more sensitive in detecting and staging distal than proximal tumors. This is likely related to the degradation in the quality of EUS imaging with distance. Also, FNA of image targets become less accurate with distance. Second, this study confirms the superiority of EUS compared with CAT scan or MRI in detecting both proximal and distal bile duct tumors. Nevertheless, EUS has a limited ability to detect distant metastatic disease and therefore should be used as an adjunct rather than a replacement for cross-sectional imaging in preoperative assessment of suspected cholangiocarcinoma. Third, we found that the sensitivity of EUS FNA in patients with a biliary stent was lower than that in patients without a stent, 70 compared to 90%. This could be related to artifacts in imaging created by the stent. The majority of those were biliary stents, plastic stents indeed, and we expect a larger negative impact of metallic stents on staging accuracy, although few patients in this study had metal stents. Whenever possible, staging should be performed prior to biliary stenting. Fourth, Although EUS was only 53% sensitive in detecting unresectable disease, this was compensated by a 97% specificity. EUS can detect major vessel involvement, ascites, celiac lymph node involvement, or metastasis to the left lobe of the liver in patients with unresectable tumors. Fifth, we found an interestingly low sensitivity of 9% only for detecting nodal disease by EUS. This could be related to the current practice of not performing a biopsy on benign appearing lymph nodes. However, a recent study demonstrated that EUS features of lymph nodes are not accurate for predicting malignant involvement in cholangiocarcinoma, and EUS FNA is recommended for all visualized lymph nodes. Sixth, I would like to elaborate on one issue about the potential risk of tumor dissemination along with a fine needle aspiration tract. To date, no studies have confirmed that in cholangiocarcinoma, although it remains a concern for proximal tumors when fine needle aspirate tract is not encompassed within the surgical resection field, as is the case with distal tumors. Therefore, if a proximal tumor appears resectable on EUS, then it might be prudent to avoid performing fine needle aspiration in this case until further data becomes available. I would like to thank you for your interest in our study.